This is Crash Course in Teaching Diagnostic Reasoning. This is Part 3, Problem Representation. I'm Paul Burgle. So let's take a simple example. A 21-year-old man is brought to the emergency room for altered mental status. Well, I may not even have to give you any more information. In fact, if I give this problem representation to a group of third-year students, they start making diagnoses right away. They tell me, hey, he's on drugs, or he's intoxicated, or he's got a psychotic break. This is new onset schizophrenia, or he's post-ictal, or he's post-concussive. People are able to generate a very rudimentary diagnosis, list of diagnoses from a very simple rudimentary problem representation. And now let's see if I tweak that just a little bit and say, hey, this is a 91-year-old woman who's brought to the emergency room with altered mental status. I start to think about very different diagnoses, right? UTI, pneumonia, polypharmacy, stroke, or subdural bleed, or maybe this is just dementia that nobody recognized up to this point. So when people talk about problem representation, they say it comes a little bit later in the diagnostic process. We would get a patient's story, we would acquire some data, and then we would try to represent their problem in a simpler way that our brain can process. But as I've shown in earlier talks, the steps of the diagnostic process are not really steps. They're all interconnected. It's very fluid. They're all happening at any given time. So the reality is, from those examples I've shown you, that we are generating hypotheses and trying to arrive at diagnoses from even very rudimentary problem representations. So I would argue that both examples of a young adult with AMS and an elderly patient with AMS are both forms of problem representation. So what does this mean? What exactly is problem representation? Any form of problem representation is the process of summarizing or abstracting a case to ease the cognitive load. And it involves some degree of semantic qualification. So it may, again, be as simple as a young adult presenting with altered mental status. But some would say ideally it should look something like this. Something you might hear at the end of an intern's presentation on rounds or in their note. This is a 77-year-old woman with HFrEF and AFib presenting with hemoptysis, hypervolemia, leukocytosis, a supratherapeutic INR, and a left-sided pleural effusion after a 1-week history of URI symptoms. And I would say that's a form of what I call problem representation by the books, a way of distilling a complex case, a patient, and bringing out the essence of the case in a summary statement of some sort. But I would argue that's not the only type of problem representation. My colleague Dr. Patel and I like to talk a little bit about flexible problem representation, which is a little bit more open-ended, but still simplifies the case a little bit. So here's an example, rash plus fever. Well, that's much simpler than thinking about all causes of fever and all causes of rash, and it really starts to invoke a set of diagnostic hypotheses. Another approach to problem representation is to simply list out the problem list and then ask learners to try to assign a diagnosis based on that. So this might work better for early learners. So if I have subacute epigastric pain, hematemesis, melena, hypotension, anemia, elevated BUN, I might want to list out these problems explicitly for somebody who can't see the pattern and ask them then to try to make sense of that problem list. And that's a different form of problem representation. The last type of problem representation is called a pivot point, which is, let's say I have a very complex patient and I find that this patient, after I do a bunch of workup, has MRI evidence of acute infarcts in multiple vascular territories of the brain. Well, I might say, hold on, hold the phone, stop everything. That is a game changer. Hold on, you have to tell me that first because there is a very limited differential diagnosis for that. Why did you waste 5 minutes presenting the patient when you can just tell me this patient has multiple acute infarcts in multiple vascular territories? We have to solve that. We have to view all other clinical data in the light of this very interesting finding. That's another form of problem representation. So let's go back to problem representation by the books. Here's what it entails. It includes who the patient is, a time course of illness, and then semantically qualified descriptors, key features of the case with no fluff. So an example of that would be an elderly woman with HFpEF presenting with acute, which is the time course, hemoptysis, hypervolemia, and marked leukocytosis accompanied by AKI, acquired coagulopathy, and lung consolidation. Those would be the key features that are semantically qualified. So I told you who the patient is, what the time course is, and some of the key features. Now there's some advantages to doing this. First of all, you can take a very complex patient and simplify them by distilling that down to the essence of the case. And if I simplify it in that way, that might only make me think of a few diagnoses, which is fine. Distilling the case in that way starts to narrow the diagnostic possibilities substantially, and it might map to some illness scripts, which we'll talk about a little bit more in the next talk. Problem representation in this way can also be done iteratively, which I'll show in a moment. And finally, if you are trying to assess learners or see where learners are at with even how they're thinking about the case, this is actually a good way to allow for assessment of high-performing learners. You say, hey, how would you summarize the case, or what do you think is going on? And they give you a beautiful problem representation. You can see that they're thinking clinically, right? Some of the weaknesses to this approach, though, are, what are the key features to put in problem representation? If somebody's got 15 things wrong with them, how do I decide to summarize them? What am I going to put in that problem representation or that summary statement? Which, of course, the other idea that fits into this is that some patients do not follow Occam's razor, right? So if somebody might have multiple things going wrong with them, if I try to summarize the case and distill it into a nice summary statement, I might end up neglecting some of the other diagnoses that are also relevant. So as I said, problem representation by the books can be iterative, and I think that's another nice way to think about using it, particularly if you're going to be leading case conferences. So you often have seen this in any case conferences you've gone to, right? You might have somebody who presents a chief complaint and history of present illness, and then the person facilitating the conference will say, hey, why don't you summarize the case so far? And then, some learner in the crowd might, stand up and say, this is an elderly woman with chronic postprandial epigastric pain. And then if you wanted to, you could start to generate a differential diagnosis there. But then you might get more history, and then you might ask somebody in the crowd to re-summarize, and they'd say, hold on, this is a lot more interesting now. This is an elderly woman with coronary disease, peripheral arterial disease, and heavy tobacco abuse presenting with intermittent postprandial epigastric pain and a pulsatile abdominal mass on exam. And you say, hold on, that's cool. We've re-summarized the case in a way, and we've perhaps eased some cognitive load here. Even though it's a little bit more complicated, we now are starting to think about more specific diagnoses. As I said, approach 2 is called flexible problem representation, or what we call flexible problem representation, which is taking a couple of key elements of the case and asking learners to generate a differential diagnosis from there. So examples would be rash plus fever, or intermittent left lower quadrant pain, or chronic dyspnea. In each of those examples, I have not given any patient demographics. I haven't told you who the patient is. I haven't told you a time course of illness, but you would still agree with me, right, that there is a more limited set of differential diagnoses for rash plus fever than there is for rash alone, or for intermittent left lower quadrant pain than for just left lower quadrant pain, or abdominal pain, or chronic abdominal pain, right? If I give it these types of qualifiers, I can already start to narrow the differential diagnosis. So I think the strength to this flexible problem representation is that it prevents premature closure. In fact, it allows for early generation of an expansive differential diagnosis, and it's very diagnosis neutral. As we'll see in a couple talks later, it also maps to schema, which is another nice way to start to think about solving problems. Of course, one of the problems with this is it's not realistic to use outside of teaching settings, unless you're trying to teach learners how to generate a differential diagnosis from a chief complaint alone. The next approach is what we talked about, was using a problem list. And from there, we can mix and match from a problem list. So I might have a complicated postpartum woman coming in with dyspnea who has many signs and symptoms. And we might generate a very long problem list for that patient. She had a recent C-section. She's got a little bit of asymmetric leg swelling. She has an elevated D-dimer. She has a history of preeclampsia. She's tachypnic. She's hypoxemic. She has a gallop on exam. She has asymmetric bilateral airspace opacities. She's a little febrile. She's hypertensive. She has an elevated pro-BNP. This is a problem list, right? Lots of things going on here. And now we can slice and dice this problem list in different ways to start to think about different diagnoses. So if we looked at it through the lens of this is a recent C-section patient who has asymmetric leg swelling, an elevated D-dimer, and tachypnea and hypoxemia, we'd say, oh, this could be a pulmonary embolism. But if we take the problem list and take different parts of it and mix and match, and we say, hey, she's got a gallop, and she's hypertensive, and she had a history of preeclampsia, and she's got these asymmetric bilateral airspace opacities and a high pro-BNP, maybe this is actually postpartum cardiomyopathy. But then you might say, oh, let's look at the problem list again. She's got a C-section. She was in the hospital recently, and she's tachypnic, and she's hypoxemic, and she has a little bit of a fever. Maybe these opacities are actually some sort of pneumonia. So you can see the strengths of this approach, right? It remains diagnosis neutral. It allows us to pick different elements of the problem list that can map to different illness scripts. And again, it can be done iteratively. The problem is that I think this is too time intensive, except for if you're trying to get early learners to try to think through the diagnostic process. And there can be too many combinations, right? If somebody has 20 different problems in their problem list, you can think of all the combination and permutations of those complaints. You would have hundreds of different diagnostic possibilities and ways to reframe the problem. And of course, again, some patients do not follow Occam's razor, so trying to group different problems in different ways may actually be the wrong approach. Each problem might be its own problem in itself. So now let's just take a really complicated case and show each of these approaches in succession and show why none of them might be effective for a very complicated case. So you don't have to read this case in detail, but I'll tell you about the case. If I were to do problem representation by the book, I would summarize this case as a 66-year-old woman with a history of coronary disease, previous CABG, dual chamber pacer, high degree AV block, proteinuric kidney disease, insulin-dependent diabetes, coming in with 2 episodes of syncope and several weeks of worsening anasarca, who was found to have restricted cardiomyopathy and nephrotic range proteinuria. Whew, that was a mouthful, right? That's PR by the books. I tell you who the patient is, I have a time course in there, and I have key features of the case. If I wanted a flexible problem representation, I might say, well, this is just a middle-aged woman with subacute anasarca. Let's think through those diagnostic possibilities. I might generate a long problem list, and I'm not going to read it for you here, but I might say she's got coronary disease, and a heart block, and nephrotic range proteinuria, and syncope, and diabetes, and carpal tunnel syndrome. And then I might try to find ways to lump together those problems on a problem list. But if I'm experienced, I might get this long case and say, hold on a second, did you say somewhere in your presentation that she had a fixed restrictive pattern of diastolic filling on her echo, grade 4 diastolic dysfunction? Are you telling me that she has restrictive cardiomyopathy? And that is what is called a pivot point. So I might have a very complex patient, but if I find out this patient has restrictive cardiomyopathy, even if I'm not a cardiologist, I'd recognize there's probably just a very limited differential diagnosis for that type of condition, right? So this is a pivot point. It's a glaringly abnormal or noteworthy data point, a finding that is too impressive to ignore, or what I'd call a showstopper, a game changer, something that you're like, hold on, hold the horses, hold the phone. We have to figure out why this patient has restrictive cardiomyopathy before we go any further. And there are clearly some strengths to this, right? If I have a very complex patient, if I find a pivot point to anchor onto, I can greatly reduce my cognitive load and say, this is really interesting. We have to start there. It might also increase my diagnostic yield, right? If I have a very unique pivot point like restrictive cardiomyopathy, that's going to make it a lot easier to solve this case. And that is going to allow me to map to some of my schema. Again, schema are coming soon. The big weakness here, though, is what if I pick the wrong pivot point? So if I'm a hematologist looking at an interesting case and say, hey, let's pick up on this anemia. This is a normocytic anemia. Let's talk through that as my pivot point. Well, there might be some other glaringly abnormal problem in the case that is something I should be picking up on instead. So if you pick the wrong pivot point, you might find yourself in deep water. All right. So those are the 4 different types of problem representation. Now let's just talk about problem representation through the lens of cognitive theories. Let's go back to our System 1 and System 2 thinking. So one form of problem representation is a gestalt abstraction of a patient, a vascular path. That's a form of problem representation, and that is a System 1 approach. We also can use System 2 as we think about problem representation, and that's explicitly summarizing a patient in written or oral format. We are deliberately analyzing the case and picking out the key elements that we're going to put into a summary statement. But once we do that, we've moved from System 2 to System 1. Right now we have a simplified view of the patient that has less cognitive load, and now we can start to explore our diagnostic possibilities through that more simplified version of the case. So as you're thinking about how to use problem representation to guide your learners, I think there are a couple main takeaways. First is that by asking a learner to summarize the case, it actually tells you a lot about what they know and how they're thinking about the case, right? Secondly, it's a good way to guide learners who are not able to see the forest from the trees, right? So if you have a learner who's struggling through a complex case and they're not sure where to start, you can use a provocative problem representation to incite their next steps in reasoning. So you might say, hold on a second, I see there's a lot of data, I see you're struggling with this case. Let's just start with the approach of saying, hey, this patient has nephrotic range proteinuria. Think about the possibilities there. And in that situation, you've taken what is a high intrinsic load task, which is trying to make sense of a lot of different data points, and you've simplified the case for them by giving them a problem representation to launch from, and now learning can occur, right? Germane load is freed up, and you can start having them think about their thinking, start putting some of what they're thinking into their long-term memory, and that's where the real learning happens. So problem representation is very helpful in these 2 ways. It allows you to assess your learners and see how they're thinking about a case. But if you can give them provocative problem representations when they're struggling, it gives them a launching point. You've simplified the task, you've reduced their intrinsic load, and they can start to think a little bit more carefully, better, I don't know, whatever that is.